Well, thank you so much for sharing that enormous experience, and we'll come back to how this integrates in the patient experience as we go forward. But now we'll have an opportunity to look at that from really two perspectives which converge. One of them is the patient experience, and Mary Jo Kupst is going to lead that discussion. And then we'll hear some commentaries from parents of children with cancer that are informed because each of our parents have scientific and medical backgrounds as well. So, Mary Jo.
Okay, I'm trying to find how I turn this on. Is it on there? Okay. Thank you. I'm going to give an overview. The area that I'm most familiar with and that I've been doing most of the work in my career has been looking at how children and families cope with pediatric cancer. This won't just be about me, but I'm going to give an overview because you're going to be hearing more specific things from my psychosocial colleagues later on in this session or in this conference. But I'm going to talk about what we've learned about the impact of diagnosis and treatment on children and families, how they cope over time, because I think it's very important to look at things over time, and a little bit about what helps or hinders coping and adaptation to pediatric cancer. But I'm also going to talk about the challenges moving forward because I believe we still have quite a few. And since this is talking about comprehensive care, that's what we really need to focus on. I'm also one of the people who started out way back, and in the late 70s, treatment was already starting to improve, but we still lost half of our cancer cohort where I was. Initially, most of the psychosocial focus, and I'm saying that not just because of psychosocial people, the oncologists were certainly a major part of dealing with this, was, helping families deal with the impending death of their child. That's not over, unfortunately, but that was mainly what happened early on. As the prognosis improved, there was more focus on, now you could focus more on the child, on the treatment, how the child was dealing with things, and so there were a number of studies of helping children deal with pain, helping children deal with side effects. Some of the medications were improving, and we saw how dramatic that was in helping with painful procedures and other treatments. So there was more of an emphasis on living with childhood cancer. It also coincided with a period of increased federal funding and ACS funding and other foundation funding for psychosocial studies, which many of us benefited from. So the psychosocial research and care increased. And we have just heard about the advances that have been made in survivorship, targeted treatment. There is more of a family focus to look at not only the child, but the child within the environment that he or she lives. And end-of-life issues are still very important, and we're still finding ways to better improve treatment. And we need to develop comprehensive integrated care. So in my talk, I'm not going to give a lot of data, but it's mostly from reviews, meta-analyses, some research, a lot of research. There have been like over 3,000 studies of just adaptation to cancer alone in children. But really, and things that parents and children have told us. I mean, I think that's a key. So in talking about, and this is nothing new to almost all of you, whether you've experienced it personally or whether you've done research or whether you've worked clinically with children and families, in the beginning there is such an information overload, and parents are expected to, and families are expected to make rapid treatment decisions and then quickly begin treatment. Along with that, you're navigating a new environment, new staff that you're going to be working with for a long time, separation from home and community. Even if you're in the same town, you're spending most of your time in the hospital. painful or distressing procedures start up, side effects start up, and then cancer doesn't occur in a vacuum. Life is still going on, and you have to deal with family, school, social changes, activities, work, and finances. As routines are established as treatment goes on, and again, I'm generalizing, but that is good, but sometimes families have told us this is a time when most of you can let down and your emotions start bubbling up. And that becomes a very difficult time as well. There are temporary and physical changes that actually become permanent. There's adherence. We were just hearing about that, adherence issues, school and peer issues, and an increased strain on the family because it doesn't stop. It just keeps going. Ending treatment is a positive time, but there's many families tell us that it's a loss of a safety net and loss of feelings of the support that you had almost on a daily basis for a long time, and transition to other and new providers. In survivorship, we've made great strides, but they still, instead of being done, there's a continuing monitoring of health. There are obviously a lot of late effects in this cohort and more medical treatment beyond cancer, which we've just heard about, resulting in changes in life plans, changes in goals, changes in personal outlook, maybe academic focus, changes in what you want to do with your life vocationally, socially, and spiritually. When relapse and recurrence occurs, there's more treatment, there's more uncertainty, there's certainly the threat of death and difficulty maintaining hope, and this is sometimes where families have told us that this was the reality. There was so much optimism at diagnosis, but here it's very hard to maintain that. And again, children are still dying with these diseases. So we're dealing with anticipating the reality of the loss of your child or of your life, and the need for talking and supporting children through this when you are, as parents, trying to deal with it yourselves, trying to face life after the child's death, trying to make sure that this child will be remembered, and there is a need for comfort and support during and after this time. It's really important to look at the developmental issues of children because it isn't a one-size-fits-all. And we all kind of know this in very young children. These are some of the things that they have to cope with, and their behavior can change. They can, attempt to control what they can't control, and you see a lot of regression. School-age children, one of the biggest things is the disruption of school and how to deal with that when that is your major work that you're supposed to be doing, and you can't see your friends, and you understand this a lot better than the younger children do. Adolescence, it's very similar, but at a time when you're trying to achieve some independence, you're thrown back into a dependent relationship with your parents, with the medical and oncology staff. And as we all know who've had adolescence, their emotions are intense anyway. And this really makes it doubly hard. And young adults, again, talking about the changes in life situations, in life plans, and also the concerns about long-term effects such as fertility, career, financial issues. For a long time it's been insurance, and hopefully it will still be good. But what have we learned? And one of the things that we've learned, and in looking at a lot of studies and a lot of things that we've done and that we know about, one of the things that comes out pretty consistently is that early factors tend to be predictive of later outcomes. It doesn't destine you to be a certain way, but the way people have functioned previously, psychosocially, behaviorally, family mental health, previously coming in, previous experiences with stress, how you coped with it, what kind of stress it was, and early coping in treatment. What happens when you first come into treatment, and how are you doing with it, and how are people helping you? Family functioning, again, the type of family functioning that is going on. Do you typically pull together? Do you typically pull apart? Do you come together? And the resources and supports that exist when you come in. Do you have good social support? Do you have insurance? Do you have are other concurrent stresses going on? And this is on top of all of those. And we found that, and developmental of the child. Do you have a toddler? Do you have an infant? Do you have an adolescent? And we found that these early factors really relate to how things go on over time. And I keep saying over time because that's my mantra, is that we have to be looking at these things longitudinally from the beginning all the way through. And then what factors have been found to influence quality of life and/or adaptation to pediatric cancer? And I've just talked about previous functioning, life events, experiences. It isn't really early response to diagnosis and treatment, but it's early, what happens early in treatment, what you bring to it, but also what is being brought to you by the team. Family and social support, and sometimes if you don't have family support, you do have good social support or vice versa, and so that's very important. And again, family adaptiveness, how well does the family deal with changes? Over, not just over time, but something that's thrown in front of them. And again, do you pull together, do you pull apart? Parent and child coping, and what I mean by that is that there's a strong sort of bidirectional relationship, that how the parents are coping can influence how the child copes, and how the child copes influences how the parents cope. And very often you'll hear parents say, if he's doing okay, I'm doing okay. But that's pretty strong, and that's been found in a number of studies. Social environmental resources, once again, the kinds of things that you come in with can make such a difference in the beginning, and again, other concurrent stresses. For quality of life particularly, from some of the reviews, poor prognosis is going to be related to it. CNS disease seems to have a stronger relationship than some of the other types of cancer, and we know why, and we know what some of the short-term and long-term effects are. The type of treatment, the treatment intensity, parent and child coping again, and sort of socioeconomic resources are strong factors. What else have we learned? Well, there's no getting around it that this is devastating to families. I can't think of how it could not be devastating. When you look at families, children and families over time, longitudinally, take them from diagnosis through treatment, after treatment, and beyond treatment. We were fortunate enough to do that from diagnosis through 10 years after treatment, but other people have been doing this as well. Most children and families are able to cope with the disease, treatment, and aftermath. Now, sometimes that statement that people have made is not interpreted the way that we really mean it. It doesn't mean lack of problems. It doesn't mean that people feel like they're falling apart and have never, in something that they've never experienced before. It's life-changing. You don't get over it, but you do learn to cope and manage it better, generally. And again, I'm generalizing a lot, but there have been a number of findings that support this. But it does look at the importance of early and continuing communication and support from the whole cancer team. What else have we learned? Well, the importance of paying attention to individual differences, and this is where when I and my colleagues are looking at how children and families cope, there's a wide variety of the ways people do. And one isn't necessarily any better than the other, using coping strategies and things like that. And it's a process, so that you can change how you respond. You can change how you perceive situations and how you act on them as time goes on. If you only take, I think one of the things, we've had some lovely cross-sectional studies, but if you only take that snapshot of one time, you might think, oh my gosh, this family is doing really, really poorly, when that's just part of the process of getting through this. And so it's really important to follow people over time. And then I had need for personalized psychosocial interventions, but that again is there. We have some really nice interventions that you're going to hear about later, but we always need to keep the individual child and family in mind as what is going to work best for whom. And then way back, we were finding when we were following families that about 25 to 30% would really need much more intervention and much more help because this was terribly devastating and it wasn't getting any better. They weren't necessarily the same people over time, but that percentage was about the same. And then I started seeing other of my colleagues, some of whom are here, and that they were finding that similar percentage too, whether you were looking at adjustment, post-traumatic stress, other types of outcomes, that significant distress or upset really needed more psychosocial care. You'll hear more about post-traumatic stress later, and generally it was found to be higher in parents and survivors, but it can lessen over time. I'm saying can because it doesn't always, but post-traumatic growth can also occur. So what is the good news? The good news is we have a greater knowledge of the psychosocial aspects of pediatric cancer, from what families have told us, from what children have told us, from looking at it, observing, measures, all kinds of things. We really have learned a lot. We have improved assessment and screening measures that have been developed that are more specific to pediatric cancer than what we were using way back, that were more general kind of psychopathological measures. We have very good neurocognitive measures that have been developed, and for example, an excellent battery that is used in the Children's Oncology group. So we've got some really good measures and patient and families reported measures. We have more promising evidence-based interventions, especially starting early in treatment. You will hear about some of them later, but especially, I would say, in the last 5 to 8 years that have been well documented and well described. So we have the good news, but what do we still need? Are we done? We are not done. Again, my mantra of we really need more longitudinal research to better understand stability and change over time. What are the psychosocial needs through and after treatment as we follow families? What are the optimal methods and timing of screening and assessment? When should we can screen in the beginning and we can assess in the beginning, but how often should we be following and for how long? Targeted or personalized interventions, especially for those who may need more or different types of interventions than what we have developed over time. And how to best ensure that psychosocial care reaches everyone who needs it, because it doesn't. We know that. So looking at from the ideal to the real, integrating psychosocial care in pediatric oncology. Comprehensive care equals multidisciplinary integration, and I think we all know that. We've worked with nursing, social work, psychology, all of the pastoral care, all of the different, we all need to be together working there. And it needs to be available. Where psychosocial care is embedded in centers, it seems to work better than if it's somebody down the street or across town, because families are not going to travel there necessarily. But there also has to be access, and again, there are insurance issues, so they may not be able to see people. So the challenges, and he's not in a room, but it is the elephant. We have fewer financial resources available. So we have less federal research support. It isn't more demand from private foundations, it's more demand on private foundations. Institutions cut positions and programs because they're trying to deal with their money problems. So we need creative solutions. Some large centers have funds to support care and research, but many do not. how to increase reimbursement, and we have to demonstrate costs and benefits. We need to translate results into care that is evidence-based, targeted, individualized, culturally sensitive, and integrated into the overall oncology treatment strategy, and find effective ways to support psychosocial care financially. So how do all children and families receive optimal psychosocial care? We need to determine the essential elements that all pediatric oncology programs must, which would be standards, and should guidelines have. That's lifted from the Livestrong standards and guidelines papers. There have been many standards and guidelines, and they've been very good. Many of the people here have developed them, but they haven't been implemented for a number of reasons. They have to be evidence-based and have strong support from stakeholders, but families, patients, people who are providing care, and influential groups. Some of us were part of the National Action Plan for Childhood Cancer that the American Cancer Society put on in 2002. And this is from the Patient Family Quality of Life Working Group. Some of these things have been happening, and they've been happening very well. But there's still a lot that we need to do. And the last one, define the required components of psychosocial support. Required components. So what do we absolutely need to have? Well, we need to develop evidence-based standards and guidelines for the psychosocial care of children with cancer and their families. And there is the Psychosocial Standards of Care project. And the aim is to develop evidence-based standards of care for children with cancer and their families throughout the cancer trajectory. The impetus for this came from the Maddie Miracle Cancer Foundation, and there is ongoing support that has led to briefings, think tank conferences, and intensive work by over 40 psychosocial professionals and advocates over the past 3 years. And this isn't next steps because it's happening now. Using the example of the adult cancer world, which you'll hear about also later in the conference, to publish and disseminate standards, achieve advocacy and support from key oncology and advocacy organizations, and achieve standards of care that can be implemented successfully across children's cancer centers. So in summary, I think we have a greater understanding of the impact of childhood cancer, although we still have to be listening to children and families, what the impact is on them. We have improved ways of delivering care. But for truly comprehensive care, we must integrate psychosocial care, increase availability, and access to care. And the only way that we can do that is to work together to advocate. And if anybody wants my references, I will be glad to send them to you. But thank you very much.